Good afternoon, everyone. I hope you guys are all doing well today. I'm Allison Elsner, and I'm the CEO of the San Bernardino County Medical Society. Thank you so much for joining us for today's town hall webinar, The Nuts and Bolts of COVID-19 Therapeutics for Providers. And we are super excited to have with us today Dr. Michael Sequeira, the Public Health Officer for Department of Public Health, San Bernardino County, as well as Dr. Ngoc Nguyen, Pharmacist with Clinic Operations, Department of Public Health, San Bernardino County, and Chelsea Koski, Program Coordinator, COVID-19 Vaccine Therapeutics Distribution, Allocation, and Appointments Team, also with San Bernardino County Department of Public Health. So we thought what we would do today is go ahead and introduce our wonderful superstar, Dr. Michael Sequeira, and then Dr. Sequeira is going to take it from there and introduce, or you can do self-introductions for Dr. Nguyen and Ms. Koski. And if you do have questions, we encourage you to go ahead and enter those into your Zoom chat, and we will get to those. We will field those. We may be somewhat interactive along the way, but if we don't get to them during the presentations, we will certainly get to them at the end. So with that, I am so very pleased to introduce our lead presenter today, Michael Sequeira, MD, Health Officer for San Bernardino County Public Health Department. Dr. Sequeira received a Bachelor of Arts in Zoology from Pomona College in Claremont and graduated with his medical doctorate in the top 10% of his class from the University of California, San Diego School of Medicine. He completed his residency in internal medicine and emergency medicine at the University of Oregon Health Sciences Center in Portland. For the past 30 years, Dr. Sequeira has worked in leadership roles at the local, state, and national levels, including as regional director of 6 of its hospital emergency departments. He currently serves as a delegate to the California Medical Association's House of Delegates through our Medical Society. And of course, he's our past president of the Medical Society. And he's a member of the steering committee of the Inland Empire Opioid Crisis Coalition. He also serves as National Risk Director for Vituity Healthcare, where he has been charged with keeping providers current with the latest clinical and research data on COVID-19. And really quickly, there's one thing I do want to say. Dr. Sequeira has done so much more than just what's in his bio and what's on paper. Dr. Sequeira, you've really represented our county as a leader in the response to and with proactive measures to heal the community on so many levels from the COVID pandemic and beyond. And you've brought this tremendous sense of alignment and camaraderie to all of our organizations, creating this wonderful kind of symbiotic relationships. We can all work together to accomplish so much more especially with these challenges we've been facing. So as Aristotle said, the whole is greater than the sum of the parts. And we thank you for illustrating that and just for all you've done. So with that, take it away, Dr. Sequeira.
Thank you. I'm humbled. Thank you, Alice, and I appreciate it. And I'm so excited. Actually, I'm excited now to be able to showcase 2 of the stars of our team as well. I'm going to let them introduce themselves, and we'll start with Dr. Ngoc Nguyen and Chelsea Koski. Ngoc.
Good afternoon, everyone. It's an honor and pleasure of mine to be with you here today. I am a pharmacist by trade, going on board to 14 years practicing as a pharmacist, spending my time at Arrowhead Medical Center as our inpatient pharmacist and a clinical pharmacist at Loma Linda Children's Hospital. Currently, I am a pharmacist with our Department of Public Health, serving our clinical operations sections, primarily handling pharmaceutical support for our health centers and our public health clinics. And due to the pandemic's COVID-19 pandemic, I'm also assisting with our county COVID response in vaccines and therapeutics distributions efforts.
Dr. Nguyen, we're having a little hard time hearing you. Is there any way that you could increase your volume or?
We'll try.
Okay.
I think it's very positional when you turn towards the mic. It sounds better. Okay, Chelsea, thanks. Chelsea.
Hi, good afternoon, everyone. My name is Chelsea Koski. I'm the program coordinator for our COVID-19 vaccine and therapeutics distribution and allocation team. Very happy to be here today to present to you some information on how to obtain the therapeutics through our county. I graduated from California Baptist University with my master's in public health, and started with San Bernardino County in June of 2020 as a contact tracer. Found a passion for public health. I mean, I've always had a passion for public health, but really working for San Bernardino County and, helping out in the COVID-19 response. So looked for additional ways in which I can expand and, do what I love. And kind of ended up in this role, which I am very happy and excited to be in. So I will hand it right back over to you, Dr. Sequeira. Thank you.
Thanks, Chelsea. So Ngoc, we can load up the slides. So today what I wanted to do was make the whole concept and procedure of COVID therapeutics much more granular. That people are wondering, why aren't we using these? And I get various questions that come from all over, like, how can my patients get this? Or how do I prescribe this? And what specifically, how do I have to do this? And what are the important elements of prescribing this in terms of drug interactions and indications and contraindications, et cetera? So that's why I wanted to bring this to the community. I really wanted to thank the Medical Society. The Medical Society I'm very proud of, and I'm a part of. And Medical Society has taken a key leadership role in communication and propagation of our response to COVID. And I really want to, Allison and the crew are just great. And also wanted to thank the HASC, the Hospital Association of Southern California, because when we want to get things out quickly, I'll hand it off to Allison and to Megan Barajas of HASC, and it really reaches the significant majority of our providers, and that's key. Communication is key in response to any kind of endemic. So what I wanted to do then today is, with the three of us, I'd like to provide the COVID setting, the milieu, what's going on with Omicron and B2, and the ebb that we're going through. And then we're going to go through the evolution of therapeutics and then the specific therapeutics. And then Chelsea's going to basically provide the resources for the providers so that you actually know where to tell your patients to go, which pharmacies, how to prescribe it, et cetera. Because it's key. We're not using enough of our therapeutics. I wanted to really emphasize that we're not using enough. And part of the key is, CDPH and FDA got out the message that there's such a scarcity. Be careful. We need to parse and meet this out really carefully. But I think we were between a combination of that approach and the scarcity approach and the ebbing of our cases, we actually were not using nearly enough of our therapeutics. So that's a big purpose of this, is to get you, the providers, to really stimulate the community and start getting this out to your patients that need it. So we'll do the next slide. With regard to the COVID setting, we're really it's important constantly to try and get the answers to these things. How transmissible is the virus, specifically with Omicron and B.2? It's also important to know that B.2 now accounts for about 70% of our Omicron, and we're 100% Omicron folks. So B2 is here. It's all around us. So and we had been predominantly B.1.1, but B2 started just 3 weeks ago, and even last week it was 55% of our whole genome sequences, and using our wastewater surveillance, which is we're doing with Loma Linda and Dr. Sinclair, the epidemiologist there. We're having a slight uptake, but when we're basically looking at all of the whole genome sequences, the variants, it's B2 now. It's 70%, and I'm predicting I'm going on record, within a week or week to week and a half, will be probably 100% B2. What does that mean? How does that compare with our other variants? Well, B2 is an Omicron. Okay, so it's really infectious. Omicron, original Omicron was one of the most infectious viruses that we'd seen. It was really close to measles. Well, I think it may pass measles now with the B2. The B2 is like 30 to 50% more infectious than the original Omicron, and the R naught for the original Omicron was 12. So that means in the absence of all mitigating factors, herd immunity, natural immunity, and masks and everything else, how many people would one person infect? The R naught for measles is close to 20, but the R naught for Omicron was 12, and the R naught for the B2 is probably around 16 to 17. And when you calculate the need for herd immunity, what do we need for herd immunity with an R naught of 16? We need about 94% of our population to have a combination of natural and vaccine-induced immunity. So this little guy is really infectious. Now, fortunately, we've got a good level of community immunity going between the people that we vaccinated, and we have to get them boosted too, because there's that whole concept of vaccine or waning immunity. So it's really important that we continue to boost, but also natural immunity. The people who were vaccine hesitant, who didn't get the vaccine, well, Omicron just, swept right through them. So it's really changed things. So what it does do is it still leaves room, because the Omicron B2 is still infecting people. It does leave room for therapeutics, and it's changed our therapeutics. And we just went over this a few days ago. We threw out the slides last week just to begin to prepare, and we've had to adjust our slides already in terms of the therapeutics, just to adjust for the emergence and dominance now of B2. Next slide. No, great. So I've already talked about the B2, but we know that the susceptibility, the vaccines actually offer a little less protection against infection for sure. Now remember that there's two mechanisms of immunity. There's the B cell induced antibody producing neutralizing antibodies. The B cells produce neutralizing antibodies, and then there's the T cells, which are the memory T cells. And also the killer T cells. The T cells are actually more important for viral immunity. So we do know that we require the IgA antibodies, the antibodies to prevent infection in the nose and nasopharynx and throat. So what's happening is with the Omicron and the B2 especially, we're getting localized nasopharyngeal infection. People. And it's regardless almost of vaccine. But then what's happened is immunity with the T cells and neutralizing antibodies has been able to really prevent significant infection. And as of this morning, we only have 41 patients, COVID patients in all of the county in the hospital. There are only 41 hospitalized COVID patients in the entire county. So it's working. Our natural immunity is holding up pretty well. And it's also changed because the other thing about our monoclonal antibodies that Dr. Nguyen will be talking about is they're really specific against the spike protein, and the variants of Omicron and B2 are almost predominantly in the spike protein. So we're bound to see some changes in susceptibility to the monoclonal antibody treatment. So, and that's what I indicate right here in that third last bullet. So sotrovimab is not effective against B2, and then we had to change all our slides because it was against B1 and B11. And bebtelovimab and is presumed effective against B2, and Evusheld was a combination for pre-exposure prophylaxis is presumed effective as well. We'll go to the next slide. So what we're going to focus on today is outpatient therapy. Okay, so the goals of outpatient therapy for COVID-19, number one, prevent progression to serious disease. We've got to do that. That's the key. We're not monitoring as much with home tests, et cetera, total cases. We're monitoring hospitalizations and deaths, though. And we're monitoring significant healthcare settings like nursing homes and hospitals. So what we want to do is prevent that progression. We don't want to overwhelm our health and medical system. We want to reduce the morbidity, the duration of the illness, and we want to reduce infectivity because we've got immunosuppressed patients everywhere, and we really don't want to have the virus infect a lot of people, because the faster the virus grows, the more people it infects, the faster it grows. The faster it grows, the more it makes mistakes, and we get new variants. So we really want to reduce infectivity and ongoing transmission, and then minimize the potential of overwhelming the healthcare system. And this last one in blue, just kind of let it go. We don't have we really want to have limited drug supply, so please order it. We want to get to the point where we don't have enough, because we want this stuff used. I just want to review basically the patient prioritization for the risk groups, for the if we had to ration them out. Remember the immunocompromised patients, and they can be anywhere from people on chronic steroids, azathioprine, methotrexate, people on monoclonal antibodies, and tumor necrosing factor inhibitors that we're using for psoriasis and ulcerative colitis and rheumatoid arthritis. All those people are immunosuppressed. HIV people with operative or functional asplenia, primary immunodeficiency, all those people can't generate. We can vaccinate them, but they just cannot generate the immune response. These kind of agents are going to be necessary, to help these people. So then we have number 2 is the unvaccinated people at risk for severe disease. Then number 3 is vaccinated at high risk of severe disease, people over 75 and over 65 with clinical risk factors. And then 4th are the vaccinated individuals at risk of severe disease, people over 65 and 65. So those are the priorities. If we had them, we would like you to use this table and prioritize them. But right now, basically anyone who you can catch, and Dr. Nguyen will give you the indications within, the first 5 days of symptoms. It's like Tamiflu. We want you to write that prescription or email that prescription, and get that patient started taking the medications, like specifically Paxlovid right away. But there's other agents that we want to talk about as well. Next slide.
Dr. Sequeira, did you see Dr. Prasad does have a question? Did you want to do that now, or do you want to wait?
Sure, if we can do it quickly. I don't want to take into Dr. Nguyen's. Hi, Dr. Prasad. Is there a chat? Is it in the chat or?
Well, she raised her hand.
Okay. Dr. Prasad, do you want to unmute?
Sorry, I'll put it in the chat. Go ahead and answer it when you have a chance, Michael. Don't want to interrupt you.
Okay, great. Nice to hear from you. Nice to see that you're here. Okay, great. So basically, besides the vaccine, and please, we really want to continue to vaccinate our patients. We wanted a boost, and remember that the second boost, or the 4th shot, has been approved for EUA. Anyone over 50, immunosuppressed people, actually all the way down now to age 12. So we really want to get people boosted and primarily immunized and boosted, and remember the whole concept of heterologous vaccination too. It's actually been shown either a natural immunity on someone who's boosted, or if you had Pfizer, you can take Moderna, or if you had a Moderna, you can take Pfizer. It actually produces a nice augmentation of immunity as well. And the other thing, remember we have this agent. It's called Evusheld, and you can try and practice to pronounce the 2 drugs in it, but it's tixagevimab and zilgagavimab. But these are just 2 shots, 2 IM shots, one day and then another day, just 2, and they will provide passive immunity to your patients who have immunosuppression. And even if they've been vaccinated, they're eligible to do this, to take this in 6 to 12 months. and Chelsea will tell you, we hardly have any orders for Evusheld, so use them, please. And then we don't have as much the agents for post-exposure prophylaxis anymore. We have Bamedi and Cassavivine and Indevamide, Reg and Co, but they're no longer recommended because of COVID. So with this, I'm going to get into the more of the nuts and bolts with Dr. Nguyen, and I'm going to turn that over. Go ahead now.
Okay. So in addition to preventions for when it comes to therapeutic management, treatments for non-hospitalized adults with COVID-19, there are a few therapies available. For preferred therapies, we do have the oral medication Paxlovid and an IV option, Remdesivir. There are two more therapies that are classified as alternative options, the Betamulovimab and the Molnupiravir. Last on the list is Sotrovimab, like Dr. Sequeira mentioned earlier. It was widely used towards the end of last year, but unfortunately due to the emergence of the BA.2 Omicron, it is now only designated to use when the BA.2 subvariant of Omicron is not a dominant subvariant, and in situation where none of the preferred or alternative options available, feasible to use, or clinically appropriate. So when looking at what factors should we consider in selecting the best treatment possible for our patients? Obviously, we want to look at clinical efficacy of the treatment options you're considering. Looking at availability of the treatment option, and kind of taking what Dr. Sequeira, it was a little bit more of a consideration in early days, but now there are more availability of therapeutics options for us in supplies-wise. The feasibility of administrating the parental medications that might not work for certain situations or certain areas that a patient might have access to. The potential of drug-drug interactions, for example, could play a role, such as our Paxlovid that we're going to go more in detail later. And lastly, the regional prevalence of the Omicron variant, or it could be any subsequent variant that we might come across in the future. Again, to kind of summarize the options of therapeutics that we have, they're listed in order from top down. Our Paxlovid and Remdesivir are top options due to their high efficacy. However, Paxlovid do have a disadvantage of a drug-drug interaction, and then Remdesivir also has a challenging factor that it requires 3 days of IV administrations. The Betamulovimab and Molnupiravir are the alternative options. Molnupiravir has a little bit less of a low in efficacy, and Betamulovimab is an IV injection, which could potential of barriers to some. As you can see, the onset of symptoms, for example, the oral medication, the Paxlovid, Molnupiravir, has a little bit of a shorter time window for us to initiate therapy. This is when it comes to the monoclonal antibodies, each one of them do have its own pros and cons, and we'll go more in details on each one of them as we progress through the presentations. So what we're going to be going through for the next section is overview of our therapeutics in details of mechanism of actions for each type, the authorized use and limitations of use, the dosage and administrations for each, and then we'll discuss about the data that supports the emergency use that was authorized by FDA. And last, to cover anything that clinicians should know when it comes to prescribing or dispensing the medication, including drug interactions or specific populations that we have to consider for. So first on the list, Evusheld are options for prophylaxis for COVID-19. This is an agent that was approved by FDA under emergency use authorizations for use in adults and pediatric patients who are 12 and up, weighing at least 40 kilograms. These are patients with moderate to severe immunocompromise who cannot be vaccinated, or vaccination is not an option for them, or may have an inadequate response to vaccinations. The Evusheld is a recombinant human monoclonal antibodies, which binds to the spike proteins of the SARS-CoV-2 virus, which is sense blocking the attachment of the virus to our human ACE2 receptor. Evucel includes two medications, the tisagenlimab and ciganlimab. The approved dosing for it is 300 milligrams of each ingredient given as 2 consecutive intramuscular shots. There are 3 ml in volume each. Evucel actually originally was approved at a lower dose, the 100 milligram of the tixaza and then 100 milligram of the ziga. So for those patients who received the original lower dose, the recommendation is for them to receive an additional supplement dose of 150 of each medication to kind of bring them up to that total of 300 milligram of each ingredients in Evucel. One thing to note for administration of Evucel, if patients are receive the COVID vaccines, the administration of Evucel should be delayed for at least 2 weeks after vaccinations. So side adverse effects wise for Evucel, it does have some nervous system events, which include dizziness, fatigues, headaches, and insomnia. There is a small chance of probability of hypersensitivity reactions, which could include anaphylaxis or injection-related reactions. In one of the clinical trials for Evucel, cardiac events were reported in participants with and these participants actually have cardiac risk factors. However, there was no causal relationship established between Evucel and the adverse events itself. For modeling parameters, is to use with caution with individuals with thrombocytopenia or any coagulation disorder. And this is primary to the fact of the route of administration of intramuscular. And then patients should be monitored for at least 1 hour after injection due to the small risk of hypersensitivity. For efficacy data on the Evucel, the proven trial provided us data for the approval, the emergency approval that FDA granted. It is an ongoing phase 3 double-blind randomized placebo-controlled trial where we looked at patients who are 18 and older who has not received a COVID vaccine, who were at increased risk of severe SARS-CoV-2 infection and who had an increased risk of acquiring SARS-CoV-2 infection due to their occupations or their living situations. Patients were given 150 milligrams of Pixka plus 150 milligrams of Cigalimab administered as an IM injection. There's 3,444 patients in that arm compared to our placebo arm. There's a little bit over 1,700 patients. So the primary endpoints that we collect from this data are symptomatic SARS-CoV infection with a positive confirmed result with a PCR test. So the result that came out of that are 8 patients in our Evucel arm versus 17 patients in our placebo arm. What that calculates out to be with that is 7 risk reductions for our patients who are on our Evucel treatment arm. There is a post-hoc analysis afterward with median follow-up period of 6.5 months, which show a similar relative risk reduction for symptomatic infections for patients who were on the Evucel. With that saying, currently right now, with the changing situation, there is no recommendation for a repeated dose. As I mentioned, there's data to support up to 6.5 months, showing that the relative risk reduction is still maintained. But it is a changing situation with our variants. And so as of now, there is no recommendation of whether those needs to be repeated. And moving onward to our second agents, Paxlovid is our first agent and our top priority agents when it comes to treatments of COVID-19. Paxlovid also includes 2 medications embedded into there. First is nirmatrelvir, which is a protease inhibitor. It is active against the viral protease, which plays an essential role in viral replication. So basically, it's interferes with the virus replication process. The second ingredients in there, the ritonavir, many of you probably have heard it before. It is a medication currently used right now for HIV treatment for boosting. In this situation, it's also used for the same thing. It's used to boost to increase the nirmatrelvirus concentrations. Paxlovid is authorized under emergency use for FDA for the treatment of mild to moderate COVID-19 in adults and pediatrics who are 12 years and older and weighing at least 40 kilograms, with positive results from SARS-CoV viral testing and who are at risk for progressing to severe infections, which include hospitalization and death. Again, it is not authorized for initiation of treatment in patients requiring hospital due to severe or critical COVID-19. It cannot be used as pre-exposure prophylaxis nor post-exposure prophylaxis. And it should not be used for that approved duration of 5 consecutive days. The dosing for Paxlovid is 2 of the 100 milligram tablets of nirmatrelvir, so total 300 milligram, and then 1 tablet of the 100 milligram ritonavir. They're given orally, twice daily for 5 days. It comes in a box with 5 blister packs, very easy to use for our patients. 1 blister used per day. As you can see in the picture, there's a morning dose side and then an evening dose side. Medication can be given without regard to food. It should be initiated as soon as possible after a COVID-19 diagnosis and within 5 days of symptoms onset. With dosing for the Paxlovid, there is a dose reduction that's needed for moderate renal impairment for estimate GFR from 30 to 60. The dose of the nirmatrelvir will be knocked down to 1 tablet of the 150 milligram instead of the 300. So in order to dispense, provider pharmacists can actually pop out the extra tablets of nirmatrelvir before it gets dispensed to the patients. For GFR less than 30, Paxlovid is not recommended for use.
So I just wanted to speak a little bit more, if you keep that quickly on the last slide, is that, so this is the med that's really effective and easy to take and easy to get out there, and our pharmacies have it. But you notice it, the way you prescribe it is 1 dose BID. But keep in mind, you know, that the ritonavir is a cytochrome P450 inhibitor, so it's going to wreak havoc on your medications of those patients that are dependent on cytochrome P450 oxidization for metabolism. So you really should run a med interaction check, Hippocrates or any of your med interaction programs to check for, especially for Paxlovid or ritonavir, but you know, because of the cytochrome P450 inhibition. And it's not, and note that the doses have 2 of the pills of the nirmatrelvir, so that you can actually, if they have renal impairment, and anyone over the age of 65, if you calculate their estimated GFR is going to be in the second category of 30 to 60 mLs per minute. So so your elderly are going to be in that second category of reduced dose because of low GFR. Okay, go ahead, Ngoc.
So to continue, for hepatic impairment, there's no dose adjustment needed for mild to moderate hepatic impairment, but for severe hepatic impairment, the treatment with Paxlovid is also not recommended. When it comes to our population of our patients who are pregnant or are breastfeeding, there is unfortunately, no clinical data available. There is some limited data available in animal studies where they show reductions in fetal weight that was observed. However, no other adverse development effects were observed. For pediatrics, there were no clinical data collected specifically in the pediatric patients. However, the authorized adult dose was expected to result in comparison exposure in patients 12 years and older with weight of at least 40 kilograms. For efficacy, the EPIC-HR study for the Paxlovid, it is a double-blind study with 246 non-hospitalized symptomatic adult patients with confirmed SARS-CoV infections. They were randomized to receive either Paxlovid or placebo for 5 days. The patients were enrolled within 5 days of symptom onset. They have at least 1 factors of progression to severe disease, no prior COVID vaccines, received or prior COVID vaccine infections, and standard of care were allowed, but the primary analysis population was limited to subjects who did not receive the COVID-19 monoclonal antibodies. One thing I do want to note of the patients, the study done at that time, 98% of the variants that were studied, collected at that time when the study was conducted were Delta. However, I do want to note that clinical, although there's no clinical data on Omicron variants, preliminary biochemical and such culture data has shown us the data that nirmatrelvir should retain activity against Omicron variant. So looking at the primary endpoints of the study, when it comes to COVID-related hospitalization or deaths from any cause through day 28 of the study, there were 8 patients in the Paxlovid arm and 66 patients in the placebo arms that was reported. And looking at all-cause mortality early to day 28, there was none in Paxlovid and 12 patients in our placebo arm. What does that mean is that our medications, Paxlovid, do have a 88% relatively risk reductions for the primary endpoint. Kind of what Dr. Sequeira is saying that compared to other agents, Paxlovid has a very high efficacy with the data we are able to collect. Thus, that's why it makes it to the list of the top list of a preferred option. Adverse events that were seen in more than 1% of our Paxlovid patients that has higher frequency versus our placebo group. Top of the list is dysgeusia, which patients report a change in taste, a metallic taste while they're on treatment, diarrhea, hypertension, and myalgia. And drug interaction, unfortunately, will be a big challenge when it comes to using Paxlovid. It is a CYP3A inhibitor, as well as it's also metabolized by CYP3A. So on one hand, it may increase plasma concentration of other medication that is metabolized by CYP3A, which could result in clinically significant adverse reaction from other medications. And in the second scenario, if patients are on medication that inhibit or induce the CYP3A, it may increase or decrease the Paxlovid concentration for patients who are prescribed that. So this loss in therapeutics effects on Paxlovid and possibly a viral resistance that comes from this decrease in Paxlovid exposure is a huge concern for if we widely use Paxlovid for a situation like that. So in general, providers should be aware to obtain to complete medication list from the patient, check for clinical drug interactions. Our COVID treatment panel actually do provide a full table of medication that interacts with Paxlovid on the link I provided. It's actually breakdown by drug, by category. If they're on this drug, consider another option, or there are some drugs that where it's not quite significant. For example, if it's a statins for cholesterol, we can consider to maybe potentially reducing down the dose or holding the dose temporarily for a couple of days while patient is on Paxlovid treatment. And then it's also covered pretty widely in the emergency use of approval fact sheets for providers too. And then moving on to our second agents for treatment, remdesivir. Remdesivir is an IV option medication. It is an adenosine nucleotide analog drug. Its main mechanism of action is the inhibitors of the RNA-dependent polymerase of the of the SARS-CoV-2 virus, which the enzyme plays an essential part in viral replications. Remdesivir do have a broad spectrum against several RNA viruses. It is currently approved by FDA for emergency use for patients. Actually, I take it back. It's currently actually approved by FDA for patients aged over 12 and weighing at least 40 kilograms for hospital patients in COVID, which is a 5 days treatment course, and then also approved for non-hospital patients with mild to moderate COVID-19 who are at high risk for disease progression. And the course treatment for it is 3 days course. In addition to that, there is also an FDA emergency use authorization for remdesivir for treatment in COVID in non-hospitalized and hospitalized children for that falls in the categories of 3.5 kilogram to 40 kilogram in weight. For this presentation, we wanted to kind of concentrate on our non-hospitalized dose for remdesivir, which is 200 milligram IV on day 1, followed by remdesivir 100 milligram IV on day once daily on day 2 and 3. And again, this is for patients who are 12 years and older and weighing at least 40 kilograms. Treatment should be initiated as soon as possible and within 7 days of symptom onset. Adverse events for remdesivir includes nausea, ALT and AST elevations, hypersensitivity, increases in prothrombin time, and then also accumulation of the vehicle that the medication makes was made in shorthand called FECD. It has been shown that it could be accumulated in patients with moderate or severe renal impairment. So with that in mind, the monitoring parameters for patients who are on this drug, we do want to monitor their renal function, their hepatic function, because the SBECD accumulation could potentially leads to renal or hepatic toxicity. Because of the medications have a small chance of hypersensitivity, we do want to monitor for infusion reaction during infusion, as well as for at least an hour after the infusion. And also monitoring the prothrombin time when patients on treatment. Currently, right now, FDA does not recommend using remdesivir when estimated GFR is less than 30 mg/min. So clinical data available for remdesivir to use was mostly from the Pine Tree trial. In this trial, patients who are laboratory confirmed to have COVID infections with less than 4 days from screening, age 12 and up, with at least one risk factor, have a symptom onset of less than 7 days, and more than one ongoing COVID symptoms were included. They were given remdesivir 200 on day 1, then 100 daily on day 2 and 3. And primary outcome from this, they look at 2 things. First was the COVID-related hospitalization or death of any cause on day 28. From our remdesivir arm, there were 2 patients compared to 15 patients in a placebo arm. That results in a 87% relative reduction in risk for hospitalization and death compared to placebo. They also look at adverse events. There was 42% in our remdesivir arm versus our 46% in a placebo arm. So moving on towards our what we call our alternative treatment. Like I mentioned, we've seen so far Paxlovid, remdesivir, their reduction in risk is pretty high. So they're categorized as our preferred options. Our next 2 options, betalovimab and entecavir. The reason why they categorize as alternative treatment is because there are more limited information on them. The entecavir has lesser risk reductions when it comes to data supporting it. For the betalovimab, it is active, again, also circulating Omicron subvariants, but there was more clinical efficacy data using this agent to treat patients who are at high risk, specifically for patients who are at high risk of progressing to severe COVID-19. Because of this main reason, it is only to use if none of the preferred therapies are available, visible, or deliver a clinical approval. Basically, acts as a backup to agents only. Betalovimab is a recombinant human monoclonal antibody similar to the Evucel we discussed earlier. It binds to the spike protein and then blocks attachment of the virus into our human ACE2 receptor. This medication is given as a single IV infusion of 175 milligram over at least 30 seconds in patients aged 12 and over, weighing at least 40 kilograms. The window of time to give this medication is 7 days from symptom of onset.
I like Beptel for that one reason. It can actually be given just as a slow IV push, as long as it's over longer than 30 seconds. So yes. Much easier.
So side of adverse events for betalovimab includes nausea, vomiting, pruritus, rash, and hypersensitivity, which can include anaphylaxis and infusion-related reaction. And I just want to note these are pretty low in occurrence, they're less than 1% on the data that we've collected so far. When it comes to monitoring parameters, considering that it is an IV injections, it should only be administered in healthcare settings for qualified healthcare providers who have immediate access to emergency medical services and medication to treat severe infusion reactions. Patients should be monitored during IV injection and also for at least 1 hour after injection is completed. Regarding clinical data to support the use of betalovimab, like I mentioned earlier, is very limited. The clinical data supporting for FDA to approve it under emergency use primarily came from a phase 2 portions of a trial called BLAZE-4 trial. Patients were enrolled in the trial were both low risk and high risk subjects. They have a lot of arms, and the information was pulled from treatment arms from 9 to 14. These patients are not hospitalized. They have more than one or more of COVID symptoms that were at least mild in severity. The study looked at the clinical efficacy from subjects receiving the one-time dose of the betalovimab of 175 milligram and compared it being alone versus being together with the BAM-added treatment of 70 milligram of BAM and 1400 milligram of the added. Treatment was initiated within 3 days of obtaining the clinical sample of the first positive SARS-CoV infections determinations. So outcome from this study, betalovimab has been shown to improve symptoms in patients with mild to moderate COVID-19. They're also shown to reduce the viral loads on day 4. However, the clinical significance on that second outcomes is still unclear. On top of that, betalovimab has been studied in individuals who have high risk factors in progression to severe COVID-19, but the efficacy analysis is very limited at this time due to the lack of concurrent placebo control arm for these populations. However, with that in total, the reason why FDA moved forward with approval for emergency use and considering this as a backup plan for treatment is they look at the whole big the total picture of the scientific evidence available, which include the phase 2 data from the study and the pharmacokinetic data, along with the non-clinical bioneutralization data from Omicron and other variants that we've seen so far. They feel that it's reasonable enough to come to the conclusion that betalovimab may still be effective for the treatment with patients with mild to moderate COVID-19 to help us reduce the risk of progression to hospitalization or death. And then on to our second oral agents, molnupiravir. Again, molnupiravir is considered as an alternative treatment along with our last agent that we just covered. It is authorized under emergency use for the treatment to mild to moderate COVID-19 in adults with positive results for direct SARS-CoV virus testing and who are at high risk for progressions to severe COVID-19, which include hospitalization or death, and for whom alternative COVID-19 treatment options are not accessible or not clinically appropriate to use. Just want to kind of emphasize again, it is not, unlike with other agents where it's 12 and up, the molnupiravir is not authorized for patients less than 18 years old. They are not to be initiated for treatment for patients who require hospitalization due to severe or critical COVID-19. They cannot be used as pre-exposure or post-exposure prophylaxis. and they shouldn't be used for longer than 5 consecutive days. So molnupiravir is a prodrug. It is a ribonucleoside that has broad antiviral activity against RNA viruses. Basically, it was uptake by the RNA polymerase, which in turn causes viral mutations in lethal mutagenesis from the virus. Because of this reason and mechanism of action, there is a small theoretically risk that the molnupiravir will be metabolized by the human cells and incorporated into our host DNA, leading to the mutation. Again, this just is by theory. But however, based on the data we collected so far, FDA concluded that the short-term treatment of this, it's only 5-day treatment, has a very, very low risk for general toxicity. The dose for molnupiravir is 800 milligram, which is 4 of the 200 milligram capsule that it comes in, taken orally every 12 hours for 5 days. It should be given without regards to food and initiate as soon as possible after a diagnosis and within 5 days of onset of symptoms. So the medication is currently being distributed now in a bottle package with 40 capsules. That 40 capsules should be enough to cover that 5-day treatments for a complete regimen. Efficacy information-wise regarding these medications, it was studied in a move-out study. Primary endpoint collected was a percentage of participants who were hospitalized or died through day 29 due to any cause. Patients included were outpatient adults with mild to moderate COVID-19 infections. Onset symptoms less than 5 days. They have increased risk for severe illness. And vaccines were initially prohibited from during the study period, and then they also excluded pregnancy individual. And then contraception is required for patients who are of childbearing age who are participating in the study. So data that was collected for our first primary endpoint, the all-cause hospitalizations for acute care and death through day 29, there were 48 patients in the molnupiravir arm compared to 68 patients in placebo arm. And then when it comes to mortality, there is 1 patient in molnupiravir arm compared to 9 patients in placebo arm. What that means for us is that the relatively risk reduction for a patient to be on molnupiravir compared to placebo is 30%. And then on top of that, the adverse events that were observed in the study that was seen in more than 1% of our molnupiravir patients, they include diarrhea, nausea, dizziness, and as you can see from the frequency, they're pretty low in numbers. Again, I just want to emphasize it's not approved for patients who are less than 18 years of age because it might affect bones and cartilage growth. It can be used regardless of COVID vaccination, even though that was part of the exclusions from the study. Breastfeeding is not recommended during treatment and for at least 4 days after the final dose. In general, when it comes to pregnancy, molnupiravir is not recommended for use during pregnancy. However, as healthcare providers, if they determine the benefit do outweighs the risk, they can initiate treatment for a patient if they counsel a patient on potential benefits and risks during treatment, document the patient is aware of the benefits, and then also talk to the patient and inform them of the pregnancy surveillance program that FDA had set up with Merck to basically to monitor the patients throughout their pregnancy. Specifically for this drug, because of the risks in our pregnancy populations, the FDA do require under our emergency use that providers have to provide an electronic or hard copy of the patient's vaccines and document that, and that patient has received a copy. They're required to review the vaccine with the patients and counsel them on, so that way they know about the benefits and risks. For patients who are at childbearing potential, providers should assess make that assessment and advise patients to use contraception for the duration of treatment and also for at least 4 days after the last dose. For our male patients who are sexually active that do have partner with childbearing potential, they are advised to use contraception during treatment and for at least 3 months after. Providers should make sure individuals with childbearing potential is aware of the pregnancy surveillance program, and they're encouraged to report all medication errors or serious side effects to the hormonal program. And I think that wraps up my part of talk for our therapeutics that we discussed, and I just want to kind of bring us back to that overview of my options available. I did not cover in details on Sotrovimab, as I mentioned earlier. It is no longer as recommended to use because of our predominance of the Omicron BA.2 right now. With that, I'm going to go pass it back to Dr. Sequeira to wrap up our clinical usage of our therapeutics.
Great, thank you, Lieu. And if we go to the next slide, this actually summarizes it. Summer had actually asked for a table summarizing all the data, and that table was really excellent. And this is another one that was just published by NIH in terms of the treatment algorithms that will help you make the decisions with regard to that, to each agent. And just keep in mind, as I do with Tamiflu, I like to actually, even if it's questionable that it's 5 days, I'll do, and the patient has symptoms and they're high risk, I will treat anyway. And they're not going to not provide it for you. So we're going to turn it over now to next slide to Chelsea, and Chelsea's going to give us very specifics about how to get your patient these medications. Go ahead, Chelsea. Thanks.
Thank you, Dr. Sequeira and Dr. Nguyen for the great information. So we can go ahead to the next slide, please.
Chelsea, we're having just a little trouble hearing you. If you can speak maybe closer to your mic and turn up your volume just a bit.
Sure, is that better?
That sounds better, yeah, thanks.
Okay, great. So just to go over the available therapeutics, we have bebtelovimab, Paxlovid, molnupiravir, and Evusheld. And these are the therapeutics that are available to order through our county process. Remdesivir is available, however, it is ordered through their manufacturing or distributors. So there are 3 different distributors that you would be able to order remdesivir through. Go ahead, next slide, please. So here we're just outlining the steps to order therapeutics. So if you are a new provider who has not ordered therapeutics previously, we have an interest form that we would like you to complete, or you could email our therapeutics team directly here at this email right here, the SB COVID-19 therapeutics at dph.sbcounty.gov. And I can also put these links and the email in the chat as well. And then the next step would be for you to register for the provider HPOP portal if you have not previously registered before. There is some issues that we come across with providers registering for HPOP, so we are happy to support with that registration process and can provide you with additional tools if necessary. And then once you are approved and registered for HPOP, you will start officially receiving our SB County Therapeutics request form. We ask that orders are submitted by close of business each Friday, and then we go ahead and submit those over to CDPH the following Tuesday, and then we send email confirmations of your requests that were submitted and information on how you could track your order. And just a note here as well, so if we are a new provider registering for HPOP, we do have to submit those to CDPH a little bit ahead of time. And so actually submitting your order for the therapeutics might have about a 2-week delay. That's a new process that just started a couple days ago. So, and next slide, please. And so if you are not currently providing therapeutics to your patients and need to direct them elsewhere, or maybe you ran out of a certain therapeutics, We do have the Therapeutics locator. It is a pretty simple to use map and that you can type in an address, city, zip code, pretty much anything, and it will come up with the facilities that do have therapeutics on hand, as well as how many they have on hand. If the facility has not reported their therapeutics inventory in the last 2 weeks, it will show that on that map, and you may need to call that facility to ensure that they do have the particular treatment on hand. Next slide, please. And then we also have some of our own county resources for you guys. So we have our COVID-19 therapeutics webpage, and it includes information on how to order. So all of those request forms are there, as well as our contact information, and then some additional information for the EUAs and just lots of stuff. So feel free to check that out. And then we also have our, as I mentioned previously, our therapeutics team that is available to help you. So we have our email that's dedicated to therapeutics, and then also this phone number here. It will go directed to Deanna. She's one of our team members who helps with therapeutics, but she is available to answer questions during regular business hours. And I just wanted to also include some test to treat information here. So our test to treat, as many of you may have heard, is a new initiative from as part of the Smarter Plan. So here's just some criteria. And so in order to be a test to treat site, you would need to offer services to all individuals, regardless of their ability to pay. The ability to conduct rapid COVID-19 testing or evaluation of at-home testing, and have providers be available to provide timely and thorough assessment and discussion relevant to treatment options, and considering the FDA requirements as well. And then have a located pharmacy ready and able to dispense oral medications. So the test to treat only applies to our oral antiviral medications, so molnupiravir and Paxlovid. And then we also have an interest form that you are able to fill out. If you are eligible, you would be labeled as a test to treat provider. And there is also a map for test to treat that HHS has provided us. And so you would come up on that map when patients are trying to locate a test to treat facility. And that is all I have. Feel free to unmute yourself or put your questions in the chat if you have any. Thank you very much.
Thanks, Chelsea. And I think Chelsea's really organized with our team. Really great mechanism. It should be really smooth. And I encourage you to explore the test to treat option as well. But the whole key is is being able to test and then prescribe and dispense. And you can do it with a local pharmacy. And remember, in emergency departments, the Board of Pharmacy has approved dispensing of therapeutics as well. They've relaxed their measures on that as well. So I apologize that we ran a little bit over. This slide set we're going to send to all the participants through Allison and the staff at the Medical Society. And I'd love to be able to, Chelsea, we can put this on our website as well too.
Oh, that's great. Dr. Sequeira, there was a question in here. You addressed part of it, but there was a follow-up about Veklury, and the comment was that Gilead claimed its mechanism should work against Omicron variants based in vitro study, but sometimes the in vitro data does not translate to real-life data such as Zithromax and hydroxychloroquine. Oh, hang on, there's more. Reduced the viral load, but did not provide mortality benefit. Would you like to comment on that?
Yeah, well, that's I didn't respond because it's kind of self-explanatory, but these have shown benefits, and that's the reason they got their EUAs. The one that's questionable is bebtelovimab, because it just barely had a borderline response, and so it's probably the weakest one of the four that Dr. Nguyen presented, but but all the others have pretty strong data.
Okay, great. Does anyone else have a question? I don't see anything else in the chat. Soteria, I'm sorry, I didn't mean to steamroll over.
No, you're fine. Actually, I think Dr. Sequeira has answered everyone's questions as they've come in. So yeah, I think we're okay.
Yeah. Does anybody, before we lose our opportunity here with the experts, does anyone else want to ask anything or raise your hand or jump in? I guess not. I guess you did answer them all. Well, all right then. Well, thank you so much, all three of you. That was just absolutely phenomenal. I think that really covered everything, and our providers are really well informed now. And it's great we have this resource. And Chelsea, we do love how you've summarized all of this. So we thank you so much. And Dr. Sequeira was talking with us. Maybe we can do some follow-up sessions, perhaps have a series of these, because as you mentioned, Dr. Sequeira, this information is changing almost daily. So it'll be great to keep everyone updated. And we appreciate all the knowledge and homework that goes into keeping this updated. It's quite a large volume of information to stay on top of. So, all right, if no one else has anything else, we thank you so much and have a lovely rest of your afternoon and week. And we will send out, Soteria just sent out the slides, and we'll send out the recording soon.
Great. Thanks, everybody.
Thank you so much.
Thanks, everyone. Bye-bye.